examination, you will see that a lot of things we have to do in eye examination. And if you have to do the full eye examination, to be honest, it takes a lot of time. It takes a lot of time. It's quite time consuming. But as we know, in the exam, we are doing only relevant examination. So what part of examination is relevant, we need to see according to the history as well. Let me go through this slide first, and then we'll discuss some scenarios as well. So first is inspection. So you can do the inspection of the eyes, and obviously all those steps before you start the examination, you are done with the history. Before you start the examination, what you do, you will say all those steps. I'm going to examine your eyes. For the purpose of examination, I can see adequately exposed. Thank you for that. And I have a chaperone to ensure your privacy. May I proceed? Yes. And you have got pain anywhere? No. I'll be gentle and quick. At any point of time, if you feel uncomfortable, you want me to stop, let me know. I'll stop my examination. All right. Can I proceed? Yes. So that's how you will do in every single station. Okay. Fine. So first is inspection. Make sure in eye examination, you can also ask one more question to the patient if you are using any glasses or contact lenses. Right? So that's going to be very, very important. If yes, tell the patient to remove that as well. That's going to be very important. Yeah. So first is inspection. So what are the things that you can mention? What are the things that you can mention in terms of inspection? Like any, again, redness, any swelling, any discharge coming, yeah? Then you can do the inspection of the eyes from the side as well. And you can do it from the back as well, right? So side, you can look for any bulging of eyeball. That's what we say. That is what we call as exophthalmos. And from the back, you can ask the patient to look up and you can look for proptopsis as well. So that's a brief inspection. Visual acuity. How do you check for visual acuity? You check it with the Snellen's chart. So this is your Snellen's chart. So they might have a small Snellen chart. They might have a big Snellen's chart in the exam. So the smaller one will be there on the table. If the smaller one is given to you, how far you have to keep that Snellen chart from the patient? So in your clinics, you might have seen the big Snellen's chart, which are there on the wall, isn't it? How far they are and how far you should keep, you should get the small one. So that's a good, big question. Small one, we usually keep at 6 feet distance. The big one, usually we keep it at 6 meter distance. That's really important. So please check if they have given you the smaller one that you may find on the table. If they have given you the bigger one, that might be on the wall. So don't miss that. And if you've got any doubt, to be honest, it is written in the Snellen's chart as well. Hold the chart 6 feet. If it is smaller one, it says 6 feet. From the eyes in good light. Check eyes separately, both with and without glasses. So if your patient is using glasses, I'm talking about which glasses? The glasses that you are using for far vision. So if patient is using the glasses for the far vision, you need to check the visual acuity twice. Once with glasses, once without glasses. All right, so that's what you do. And how far are you going to keep the chart from the patient? If it is smaller chart, 6 feet. If it is the bigger one on the wall, it is 6 meters. Okay, so that's what you do. Now, this is how you check the visual acuity. Tell the patient to start reading from the topmost word, like E, for example, in this, and then they have to read it till the end. Okay, now, if they have not given you Snellen's chart and you have to check the visual acuity, is there any way I can do it? Yes. So what you can do finger counting as well. You can do finger counting as well. How? Just tell the patient to cover one of the eye, and then you ask the patient how many fingers you can see, and then you go a bit far and ask how many fingers you can see. And the same way you can check the other eye as well. So you can do finger counting as well. Then the color vision can be checked by Ishihara plates. So Ishihara plates, simple plates, I mean, it's just a booklet. Tell the patient to read it. There are some colored picture, colored numbers. If they can give you the number, it means their color vision is absolutely fine. I mean, for some countries, whenever you go for your driving test, they make you read a booklet for the color vision. That's what is your Ishihara plates. Okay. Then we have got the visual field test. You'll check the visual field a visual field test. So if you think patient has got problem with the peripheral field of vision. So for example, if I'm looking straight, I'm covering one of my eye, I'm looking straight, I can still see on the side as well because my peripheral field of vision is okay. If it is not okay, what's can happen? Patient might have some findings as well. Patient might have some findings as well. Patient might have tunnel vision, patient might have bitemporal hemianopia, patient might have homonymous hemianopia as well. All right, so for example, if I'm covering this eye, this is my temporal vision and this is my nasal vision. This is my temporal vision, this is my nasal vision. Okay, so what can happen if, for example, for this eye, nasal is gone, temporal is gone. This eye as well, temporal is gone, nasal is gone. So what is it? Tunnel vision. If this eye, temporal is gone, this eye, temporal is gone, but nasals are intact. What is it? Bitemporal hemianopia. If this eye, temporal is gone, this eye, nasal is gone. What is it? Homonymous hemianopia. Which side? The side temporal is gone. All right. So the explanation and how it is done, you can find in another video. That's absolutely fine. But this is what I mean by visual field X test. It is done to find out that if there is any problem in the peripheral field of vision. Then you have got blind spot. Don't worry, you do not have to do it in the exam, so you can just skip it. Because if there is any finding in the peripheral field of vision, if there is any finding in the peripheral field of vision or visual field, you are not supposed to do blind spot. So ignore that. Then you have got pupillary reflexes. You can check for direct and consensual pupillary reflexes as well. Now, the main thing that comes in eye examination is fundoscopy. Now, make sure before you do fundoscopy, we need to prepare the patient. So, what are the preparation required? Number one is you have to dim the light. You have to dim the light. Number one. Number two is you need to put the eye drops. Now, before you put the eye drops, what you have to do? Before you put the eye drops, what you need to do? You make sure you rule out acute angle closure glaucoma. That's really, really important. Yeah. Ask the patient. In the question itself, you can rule out acute angle closure glaucoma. You can ask if you have got any headache, if there is any pain in the eye, any pain at the back of the eye, any color halos around the light, or any nausea, vomiting, any red eye. So all these questions you can ask to rule out acute angle closure glaucoma. And then only once I've ruled out acute angle closure glaucoma, then I'll tell my patient that I'm going to put some eye drops in your eye. And when you put dilating eye drops in the patient's eye, what's going to happen? What's going to happen? They will not be able to see things very clearly. It's going to be blurry for some time, for a few hours. And then what we do, we give some standard general advices to our patients. So what are these standard general advices that we need to give to the patient? That number one, do not drive. Number two, don't sign any legal documents. And don't operate on any heavy machines for the next few hours, right? Because this is really important, because the thing is, if patient cannot see, and if they're driving or if they're signing any legal documents or operating on any heavy machinery, it can injure them, isn't it? So you advise these things to the patient. Now, a lot of candidates ask me, so if patient has got acute angle closure glaucoma, can I not do fundoscopy? The thing is, you can do fundoscopy, that's absolutely okay, but you don't have to put the dilating eye drops. Why? Because patient patient pupils, they're already dilated. So acute angle closure glaucoma is a contraindication for the eye drops, not for the fundoscopy per se. So this is very important. Yeah. So these are the things. So you need to have dim light, you need to put the eye drops and mention about these general advices as well. And then what you do, you will do fundoscopy. So first is you do the red reflex. What is red reflex? You just check the red reflex, just see from a 1 arm distance, you shine the light in the patient's eye with the help of a ophthalmoscope. You will see a red dot in the patient's eye. It means the media is clear. It means the media is clear. You can see the back of the eye. So it means you are able to go ahead for your fundoscopy. I mean, if patient has got mature cataract, you cannot see the red reflex, so you cannot see the back of the eye, and there is no point of doing fundoscopy. So that is the thing. So just check the red reflex, and then you go very close to the patient and you do fundoscopy. In fundoscopy, just need to be very careful about few points. You can see in our other video, but I'll tell you, when you're examining the right eye of the patient, you check it with your right eye and you hold the ophthalmoscope in your right hand. You hold the ophthalmoscope like a mic and you check the right eye of the patient. You hold it in your right hand and you check it with your right eye. If you're examining the left eye of the patient, you hold it in your left hand and you check it with your left eye. So right, left, left. Do not break this rule. That's the main thing. Patient might have problem in one eye, patient might have problem in both eyes. You have to examine both the eyes in the exam. Always start with the normal eye, then only you will check the affected eye. That's what you are supposed to do, right? So this is your proper eye examination. Now, you cannot do everything in every scenario. You cannot do everything in every scenario. Now, as a doctor, if I'm wearing glasses, should I take off my glasses when I'm doing fundoscopy? Not really required. You can go on with your glasses as well. That's absolutely fine. Okay. Now, let's discuss some scenarios that you might see. And also, as I said, if it is tunnel vision, if it is bitemporal homonymous, there are reasons behind it as well. We'll come to this slide. Now, let's have a look. Your FY2 in GP, your patient is 43 years of age, presented with some visual problem. This is the first time patient is coming to you. You don't know about the past medical history. Talk to the patient, assess and discuss the management. Okay, fine. So how can I help you? This patient said to me, doctor, my wife has booked this appointment for me. Okay. So if you can tell me what exactly was the reason why your appointment was booked. He said, I scratched the side of my car yesterday. Okay. Is it the first time that it has happened? No, it has happened previously as well. This patient is saying, for me, I'm absolutely okay. I don't have any problem. It's my wife. She thinks I've got problem with my vision. Okay. She thinks you have got a problem with the vision. Okay. Why she thinks? Because I scratched my car yesterday and it has happened previously as well. And he's not having insight. He's like, doctor, the parking place is really tiny. So it can happen with anyone. If you park, you can also scratch the car. But she thinks I've got problem with my vision, but I can see properly. So usually, whenever the patients have got the problem with the peripheral field of vision, they don't have insight. They don't feel they have a problem. So that could be the reason. So I'm just hoping, I'm just thinking that could be one of the reasons. But obviously, I have to take history now. So patient is scratching. Anything else? No, doctor. Now, what I will do, I will ask lots of associated symptoms as well to make sure what exactly is happening. So I'll ask any, for example, any loss of vision, any double vision, any blurring of vision. What else I can ask? I can ask for any headache, any pain in the eye, any pain at the back of the eye, any color halos around the light, any red eye. So ask all those questions because you need to rule out lots of differentials as well. What exactly is happening? Now, is there anything specific? Because patient is saying, while I was parking, I scratched my car. So it will make sense to ask which side. Because, for example, if it is a problem with the peripheral field of vision, is it on the left side or right side? So that could be very important as well. So that you can ask which side of the car. Right. And one very important question that you can't afford to miss would be that you're going to ask is, by any chance, if he's driving, by any chance, if you are getting accidents quite frequently, what else you can ask? While walking, if you bump into people, if you bump into the wall. That's very important because when they're walking, what they can see, they can just see what is there in the front. They might not be able to see on the side. So what happened while walking, they bump into people, they bump into wall, they bump into the door. That's quite important. So you can't afford to miss this question in these kinds of scenarios, right? So I asked all the associated symptoms. And let's see what's positive, but this is going to be positive. That's very important. You can quickly go to past medical history. I mean, any medical condition, any family history of any problem. Now, in past medical history, I've got so many questions to ask. Any past medical condition, any medication, any allergy, any surgery, any hospitalization. Please skip everything. You don't need anything. Maybe just ask family history and just move on. You cannot afford to ask every single question, right? You don't have that much of time. Now, I've seen a lot of candidates, what they do, they go for lifestyle history. They go for lifestyle history. And what they're asking, whether do you smoke? Do you drink alcohol? What's your diet like? How's your physical activity? Come on, these are not at all required in this particular scenario. Why are you wasting your time? So I've seen a lot of candidates, they're asking these questions, which are not required at all in this case. I'm not saying in a combined station you should never ask lifestyle, but I'm saying in most of the cases you may not need to ask those questions. All right, that's the thing. Now, in past medical history, should I ask about diabetes? Should I ask about hypertension? See, you can ask anything, but this patient says, I don't have any problem. Because if patient has got diabetic retinopathy, do you think patient will have some problem with the vision as well? But this patient is, I can see properly, I don't have any problem. Then why did you come? Because my wife sent me here. Why? Because I scratched my car. It's not a diabetic retinopathy history. It's not a hypertensive retinopathy history as well, isn't it? So you can ask past medical history and family history, that's it. But even if you miss it, you won't miss any mark from it. That's absolutely okay. Yeah. Now, after that, you're going to do the examination. So in this station, in every station, whenever you enter, especially in combined station, you need to see what I was given in the room. So when you enter, they gave you a Snellen's chart in this room. You have got a Snellen's chart and you have got a white head pin. White head pin. There is no fundoscopy mannequin in this. There is no fundoscopy mannequin in this particular station in the room. So what happened is, Snellen's chart, white head pin. So what they are expecting us to do, peripheral field of vision. Now, in terms of examination, what are you going to do in this station? First thing, I'm going to check for visual acuity. Now, should I do inspection? Should I do inspection in this station? Yes, you can do it. Even if you miss it, that's absolutely fine. It's not going to make any difference in your management, in any difference in your marking. Visual acuity, it is must. Then what is the main thing that I should do? The X test. What is it? So you need to do the peripheral field of vision. And what's going to happen? You will get a problem. You will get a problem. Which problem? So patient might have tunnel vision. Patient might have bitemporal hemianopia. Patient might have homonymous hemianopia. See, tunnel vision, bitemporal, this is not the diagnosis. What is it? It is just a finding. It is just a finding, but there is a reason behind it. What can be the reason? For tunnel vision, it could be glaucoma, it could be pituitary tumors, it could be retinal detachment, it could be optic neuritis. And this is what you need to discuss in the management that I'm going to tell you why. If it is bitemporal hemianopia, 90% of the times it's pituitary adenoma. 90% of the times it's pituitary adenoma. But it could be meningioma, could be craniopharyngioma as well. That's absolutely okay. If it is homonymous hemianopia they have given you, it could be stroke, it could be space occupying lesion, it could be trauma, it could be infections, right? That's it. So what happened is, what you got? Visual acuity, X test, and what else I'm supposed to do? Can I do pupillary reflex? So if you have got time, you can do pupil reflexes as well. Now, fundoscopy you can do, but as I said, they don't have fundoscopy mannequin, so you can't do that as well. So what I'm doing in terms of examination in this particular station, I'm doing visual acuity and I'm doing X test. These two things, if you do, that's more than enough. Now, what is the management here? Management is to find out the problem. For example, I got tunnel vision. So it could be glaucoma, could be pituitary tumor, could be retinal detachment, could be optic neuritis. So what I'm supposed to do? So number one, what I'm going to do, if it is in GP, I'll refer this patient to the ophthalmologist. That's number one. What they will be doing? Number one, they will be doing fundoscopy. Yeah, so that they can find out the things. Another thing that they can do is that they can check the eye pressure. And the main thing is they have to go for the scan only. How will you find out pituitary tumor? How will you find out meningioma, craniopharyngioma? You have to do a scan only. That's it. So this is how you're going to be able to find out what exactly is happening, right? And make sure you do the urgent referral whenever patient has got peripheral field of vision problem. Now also you tell the patient not to drive as well. Tell the patient to inform DVLA as well. Ask him one more question you can't afford to miss. How did you come to the clinic today? So what do you think? How did he come? He might say, I came by driving. Do you think it is safe for him to drive back home? No. So tell him you can call somebody who can pick you up. So that is the thing that you need to do as a part of management. Okay, so this is your whole scenario. Can it be done in 8 minutes? Of course, why not? What's the problem? If you do not ask unnecessary questions, if you do not do unnecessary things in the station, you can definitely manage it in 8 minutes. Okay, that's the main thing. Let's have a look at another station as well. So fundoscopy, I'll discuss about these 4-5 scenario: normal fundus, retinal detachment, ocular toxoplasmosis, papilledema, and diabetic retinopathy. Let's see. So let's have a look at this scenario. Your FY2 in A&E, the patient is 66. We have got a female patient. Presents to the hospital complaining of loss of vision in one of the eye. Talk to the patient, assess the patient and the management. All right. So what you are gonna do in this station? Always go with the, how can I help you? Always ask open question first. Always ask open question first. Patient said, I can't see from my left eye. For example, that's the presenting complaint. Acknowledge it, empathize with the patient. Now you need to ask few questions, you need to elaborate it. First with the open question, then obviously with the closed question as well. So I can't see. So ask if it is a complete loss or if it is a partial loss. If it is painful, if it is painless. Yeah. If it is sudden, if it is gradual. Very important. So your patient said a few things to you, doctor. It is painless, sudden, and complete loss. All right, fine. So I will elaborate that. Now, what else you're going to do? You will ask the patient, what about other eye? Remember, guys, anytime if you get a scenario on eye, you get a scenario in ear, you get a scenario on breast, if there's a problem in one ear, you ask about the other ear. If there's a problem in one eye, you always ask about the other eye as well. So this is really important. Yeah. So my other eye is fine. Okay, that's absolutely okay. So what else I will ask? I will ask, do you have any other symptoms? See guys, always go for an open question. Always go for an open question. That's gonna be making your life easy. Any other symptom? Yes, doctor, I have got headache as well. What should be my next question? Tell me more about headache. Doctor, it is on the left side here. Left side temporal area getting worse on chewing and combing. Getting worse on chewing and combing. What does it mean? It is simply going towards giant cell arthritis. Giant cell arthritis you will see in elderly females. Who is our patient? A female 66 years of age. And we know giant cell arthritis can involve the eye as well, can lead to loss of vision as well. So maybe that's the case that you're dealing here, isn't it? So now what you do, now you understood it's an emergency. You have to be very quick with your history. Now don't waste time. Don't waste time. So you can ask maybe because we know giant cell arthritis is an autoimmune condition. Patient is gonna be prone for other autoimmune condition as well, most probably. Which autoimmune condition I'm talking about? I'm talking about polymyalgia rheumatica. Polymyalgia rheumatica. So ask the patient if they have got morning pain or stiffness in shoulder or pelvic girdle. These patients, when they have GCA, they are prone for MI, prone for stroke as well because of giant cells. So ask for chest pain, ask for maybe shortness of breath, ask for any weakness in any part of the body. That's it, done, done. Now, past medical history, lifestyle history, come on, who cares? Who cares? That's what I'm saying. Whether this patient is drinking alcohol, what's his diet like, who cares about that? Of course, smoking is a risk factor. If you ask, it's okay. Even if you mix, that's absolutely okay. No problem at all. Just move on, move on. That's the thing. Now, I've seen a lot of candidates, they're wasting 2 minutes of time asking, have you been diagnosed with a medical problem? Any medication you're taking? Any allergy? Any surgery? Any hospitalization? Any family history? Do you smoke? Do you drink alcohol? How's your diet like? How's your physical activity? Come on, she has lost the eye just an half an hour ago, and you're asking these questions. It is not going to make sense, right? So please do not waste your time. We need to understand the seriousness of the problem as well and need to act fast in these situations. Yeah, so do not waste much time. When you enter into the cubicle in this particular station, what you saw, there is a fundoscopy mannequin as well. There is a fundoscopy mannequin as well. Now, what are the examination things I'm going to do in this station? So what are the examination points I will be doing? Inspection, even if you miss it, it doesn't matter at all. Yeah. Visual acuity. See, the thing is, patient said, I can't see completely. I can't see anything at all. And there's no balance chart. So if you want to do finger counting, you can do, or even if you miss it, that's absolutely fine as well. Do I need to do visual acuity? See, what is the reason behind doing visual acuity in this particular scenario? Your patient never said that I'm bumping into the people, I'm not bumping into the wall. He never said any of those things. So do I need to do the visual field? No. See, whenever you go to the eye specialist, do they check your peripheral field of vision all the time? No, I don't think so. I've been to the doctors a few times. But they have never checked visual field or X test on me. They have never done. But yes, they have done fundoscopy on me. They have checked my fundus. I have gone to a few doctors till now in my life. So this is what you have to do. Depending on the history of the patient, you will decide what examination you are supposed to do here. So patient said, I can't see anything. When you go in the cubicle, you also see the fundoscopy mannequin. The history is complete loss all of a sudden, painless. And fundoscopy mannequin is there. So what you're going to do, you will be doing fundoscopy here. You will be doing simply fundoscopy there. Make sure you prepare the patient. So how the preparation will be done? Prepare the patient for fundoscopy. So what preparation I'm talking about? Make sure you dim the light. And what else? You mentioned about that I'm putting the eye drops as well. And before eye drops, what you're going to do? Acute angle closure glaucoma, you're going to rule out. Fine. And then what you're going to do? You will just check for the fundoscopy. That's it. Now, when you're doing the inspection, should I do it on the mannequin or I can do it on the patient? You can do it on the patient as well. So you can do the inspection on the patient as well, but definitely fundoscopy will be done on the mannequin. So sometime when you're doing the inspection on the mannequin, when you're doing it on the patient, they might say, do it on the mannequin. Then it's absolutely okay. You can do it on the mannequin as well. Now, when you do the fundoscopy, what do you think what you're going to get? Patient has loss of vision in one eye and it just happened, say, half an hour ago. Just happened half an hour ago. So what do you think what you're going to get in the fundus? The thing is, half an hour, 30 minutes history is not going to make any changes in the fundus. What you're going to have, you will still have normal fundus. See, make sure you mention about this. Make sure you mention about eye drops, everything. You are not putting the eye drops, isn't it? You're just mentioning it to the patient. And 30 minutes of history will not be making any changes in the fundus. Still, you will be examining both the eyes. If patient has got the problem in the left eye, you start with the right eye and then you will check the left eye as well. So you'll be checking both the eyes. And what you will get? You will get a normal fundus. Don't say it's just normal. You need to verbalize it as well. You need to tell them what are you looking for in a normal fundus. In a normal fundus, first of all, you're looking for, I can see the optic dust. I can see the optic disc. Optic disc and cup ratio is normal. You have to mention that. I can see the disc. It's a bit pale yellow in color. I can see optic disc cup ratio is normal. I can see the vessels originating from the disc. They are normal in caliber, right? Macula on the other side looks healthy. So most probably, what is it? Most probably it is normal fundus. So this is something that you need to verbalize. You need to say a couple of lines. Just don't say it's normal. Say a few lines. That's how it's gonna be. All right. I can send you all the pictures, all 36 findings that we have in total. I will send you. That's absolutely okay. But remember, whenever you verbalize few lines at least. And you're going to do it in both the eyes. So in giant cell arthritis, if it is a bit longer time, if patient has presented to you after some time, then they can have some findings on the fundus as well. And what is it going to be? It is going to be CRAO, central retinal artery occlusion. They might have. But if it is only 30 minutes or 1 hour history of vision loss, they may not have any changes on the fundus as well. They will have normal fundus. Okay, that's what you need to do. And you can verbalize all those things as well. Right, so history, very brief history. Examination, what you're doing is just the fundoscopy. That's what you're doing. What's the management? Management is we're going to give IV steroid. That's the management. IV steroid for 3 days, then you shift it to oral steroid. Patient is going to take it for 2-3 years, long time. The other medication you're going to give is aspirin, bisphosphonates, and all other things as well. But main thing is addressing the patient's concern. Patient will have one question for you. Patient will have one question. Doctor, am I gonna get my vision back? Am I gonna get my vision back? I can see you are concerned about your vision. The thing is, you have come to us early, so we can start the progression, we can start the treatment as soon as possible, so we can prevent it from happening in the other eye. But I'm really sorry, for this eye, it's unlikely you will get the vision back. All right, so that should be your answer. Okay, that's what is and how it is done, right? So examination, where are you going to do? You can do it on the patient if you are doing inspection, but fundoscopy obviously have to be done on the mannequin. In terms of red reflex, you can do it on the patient as well. But if they don't allow you to do it on the patient, just show them the technique, how it is done on the mannequin. Mannequin will not have the red reflex because it is a mannequin at the end of the day, but show them the technique, how it is done. And then what you do, you will do the fundoscopy on the mannequin. That's it. So this is how you can do it in 8 minutes time. It's doable. It's doable, guys. Now, okay, there's another one. So you are in the GP surgery. Samantha, patient is 53, has come to you with some problem in her eye. It could be in GP, it could be the scenario of A&E as well. All right, so talk to the patient, assess and address her concern. When you enter into the cubicle, what else you saw? The patient is there and you have got a fundoscopy mannequin as well. You have got a fundoscopy mannequin as well. All right, so patient is saying, doctor, I have got some curtain falling like feeling. Doctor, I've got curtain falling like feeling. Yeah, I've got curtain falling like feeling. So what is it? See, we are an FY2. And as an FY2, we can't figure it out in terms of fundoscopy, everything in very clear way. Yeah. Because who we are FY2. So the history that they give is actually enough. The history is enough to make the diagnosis. But what exactly they want from us? They just want to see, do we know how to handle these instruments? Do we know how to prepare the patient for fundoscopy? That is the main thing. That is the main thing, right? So this patient is saying that I've got curtain falling like feeling. Anything else? Patient is saying that I can see some color floaters also. And you can ask lots of other questions, all the associated symptoms. If patient has got any loss of vision, if a patient has got pain in the eye, patient has got nausea, vomiting, patient has got any blurring of vision, all the questions you need to ask just to rule out some differentials as well. All right, that's the main thing. So angle closure glaucoma, that I can rule out. Migraine, because sometimes in migraine you will see patient has got some floaters and all, so that you can ask if the patient has got any headache or not. That's very important. Yeah. And wavy lines, macular degeneration, so that also you can ask, but I think patient is 53, you may not see macular degeneration that early as well. Okay, so what we are doing, patient has got curtain falling like feeling. I'm going to elaborate that a bit more. Is it all of a sudden or was it gradual, doctor? All of a sudden it happened. And then I'm ruling out some differential. I'm asking some associated symptoms as well. All right. Then see, retinal detachment, the main cause, sometimes it could be just idiopathic as well. Sometimes it's because of trauma. Mostly you will see it's after surgery. For example, you have done a cataract surgery, and after surgery, this is what it can lead to, right? So that's something that you can ask. So quick past personal history that you need to take here. I mean, don't go into detail. Do you smoke? Do you drink alcohol? How's your diet? Come on, these questions are again not important here. Just leave those questions. Yeah. Now, what is there in the cubicle? You have got the fundoscopy mannequin. So what you do, you go and do the fundoscopy. That's it. That's it. Should I do visual acuity here as well? Yes, you can do. So what you can do when you start, can I do inspection? If you see you have time, you can do that as well. Can I do visual acuity with the help of Snellen's chart? Yes, you can do it. Can I do peripheral field of vision? The thing is, did the patient tell you I've got problem with the peripheral field of vision? I'm bumping into people, this and that. No, so you don't have to do it, right? Then what else you will be doing? You will be doing fundoscopy. That's it. That's it. So inspection, maybe yes, maybe no, visual acuity and fundoscopy. Make sure you don't forget to prepare the patient for fundoscopy by saying dimming the light, and what else? What else? And putting some eye drops. And before putting the eye drops, what you're gonna do, you're gonna rule out angle closure glaucoma as well. All right. So now the patient is ready, and you give some warning signs as well. Don't drive, don't sign on any documents, don't operate on heavy machinery as well. Same things. And then you will check the fundus. Check the red reflex and you check the fundus. What you will see in the fundus. This is what you see in the fundus. So area of bullous retina showing area of elevation with the fluid. That's what you will be seeing. That is a typical of a retinal detachment. Okay, so in this station, what I'm going to do, I'm going to do inspection. If they have got Snellen's chart, I can do visual acuity. If they don't have Snellen's chart, I can check it with the finger counting as well, and then I have to do fundoscopy. I don't think so this examination will take more than 2 to 3 minutes of time. And I don't think so the history that I told you will take more than 2 to 3 minutes of time. So within 5-6 minutes, you can definitely do your history and examination. Now, what is the management? Management is, first of all, if it is A&E, admit the patient. If it is GP, just refer the patient same time. There are same day, or you can say immediate referrals as well in the eye. So this is what you're gonna do. And what's the treatment? Treatment is surgery only. So we have got retinal tear. We have to do the surgery only by laser or cryotherapy. You can do, and later on we can just put some eye drops as well. But mainly it's a surgical treatment that you need to do for this patient. Tell the patient not to drive, inform DVLA and everything. Right? So that's what you do. Can I do it in 8 minutes time? Of course. If you don't ask unnecessary question, you can definitely do it. Yeah. Have a look at another one as well. You have to in GP surgery. Patient is 54 and presenting to you with the blurring of vision. Patient is presenting to you with the blurring of vision. Okay, what we're gonna do? You will elaborate about this blurring of vision. Yeah, elaborate. Then obviously, patient has a problem in the eye. You will ask other associated symptoms of the eye as well with the blurring of vision. If you've got pain in the eye, pain at the back of the eye, color halos around the light, red eye, nausea, vomiting, any loss of vision, blurring of vision, double vision, right? Headache, All those questions, photophobia, any discharge coming from the eyes, all the questions related to the eye, are you bumping into people? All those questions you will be asking. This patient is mainly saying blurring of vision, right? And I did rule out some differentials as well. So there's nothing like that. So, whenever patient has got problem with the eye, whether it is loss of vision, blurring of vision, anything, you always ask the patient about psychosocial history as well. That's very important, isn't psychosocial history? Whom you are living with. Do you think it's important? Yes, it's very important. It's very, very important to find out who this patient is living with. So don't miss that question. And here you can get something very important because ocular toxoplasmosis, how you get ocular toxoplasmosis? One of the main reason is if you are living with the cats. So it is when you are dealing with the like cat feces, raw meat, so and you're immunocompromised, the chances are that you might get toxoplasmosis gondii infection. Right. So that is the scenario that they're given. So it may be very difficult for you to find out only on the basis of your history. So I always say this exam is not only medical exam. So when patient has got loss of vision, blurring of vision, you ask whom you are living with so that you have got the support. And this patient might say, Doctor, I'm living with the cats. Living with the cats. All right. Thank you for letting me know. Yeah. So in ocular toxoplasmosis, if patient is immunocompromised, if patient is pregnant, that's very important. And if patient is dealing with the cat feces or raw meat, that is a risk factor of getting ocular toxoplasmosis. That's the main thing. Again, in most of the eye cases, you have got immediate referral. So if the patient is coming to the GP will make the call straight away to the clinics, to the eye clinic, and patient will be sent to the eye clinic maybe in a few hours on the same day, and the patient will be seen by the specialist. Right. Now, what you're going to do here in this case as well, patient has got blurring of vision. So in terms of examination, what I'm going to do, am I going to do the inspection? You can do the inspection. That's absolutely okay. If you don't have time, struggling with time, just skip that as well. Right. Number two, what you have got. Number two is I would do the visual acuity with the help of Snellen's chart. Right. If the Snellen's chart is not there, what I can do the finger counting as well. And number three, what I am going to do is the fundoscopy. That is it. Right. Fundoscopy, do I know how to prepare the patient? Yes, I know how to prepare the patient. So you want to dim the light and you want to talk about the eye drops as well. And before eye drops, you have to rule out angle closure glaucoma as well and give some warning signs to the patient as well. Which warning sign? Don't drive, don't operate on any heavy machinery, and don't sign any legal documents. So this is something that you need to do. Once you're done with the fundoscopy, first of all, what you're going to get in the fundoscopy, that is what you're going to get in fundoscopy. The macula is this area and you'll have a macular scarring there. So pigmented clumps in the macular area with the chorioretinal atrophy and scarring, that's what you see. And the pallor in the optic disc as well, that's what you will see. That's your macular scar toxoplasmosis, that's what you will get. So don't just say that I can see this toxoplasmosis, say a few lines about the explanation as well if you really want to score high in the exam. Okay. Now, what's the management? So management is actually symptomatic treatment. Management is symptomatic treatment. In the exam, just find out if the patient is immunocompromised or not. Your patient is having PMR and patient is taking steroid, which is going to make the patient immunocompromised, and patient will be prone for lots and lots of infections, right? One of them could be this. So what you're going to do, you will be giving antibiotics for the treatment as well. Antibiotics will be given for the treatment. So that's how it is. Otherwise, it's going to subside on its own. However, if the patient is immunocompromised, the patient is taking steroid or having any treatment for cancer or something, then what you're going to do, you will be going with antibiotics. Okay, and don't forget to give the warning sign, follow up, and you finish the station. And if it is cat feces, so tell the patient to be careful on that. Tell them this is a risk factor as well. Right? Okay, let's have a look at this one. You are in the GP surgery. Patient is 46, female patient, came to you with the headache. Patient came to you with the headache. Talk to her, assess and address her concern. Yep. So now what I'm going to do, patient has got headache. So what you are going to do, you will elaborate on the headache. You will elaborate about the headache. So number one, when you enter into the cubicle, what else you see? There is a fundoscopy mannequin there in the room. There is a fundoscopy mannequin in the room. So that's quite helpful. So what you're going to do, patient has got headache. What you're going to do, elaborate on the headache. This patient said it's there all the time, but mostly in the morning time. In the morning time. Okay, that's fine. It's giving me a bit of idea. Morning headache. Okay, helping me. But why they have kept fundoscopy mannequin? Let's see. Anything else? Always, guys, go with the open question. Anything else? Doctor, I have got blurring of vision as well. Blurring of vision whenever I'm bending forward. Whenever I am bending forward, what I get? I get blurring of vision. I've got headache mostly in the morning. I've got blurring of vision when I'm bending forward. Fine. Anything else? No, doctor. Now, blurring of vision. Ask more question. Any loss of vision? Headache is there? Any pain in the eye? Pain at the back of the eye? Color halos around the light? Double vision? Blurring of vision? Uh, bumping into people? Ask question about the eye, isn't it? Now, this patient sometimes says, I've got nausea, vomiting as well. All right, that's it. So can I take history in 3 minutes time? Of course I can. Now I've got fundoscopy mannequin in there. Okay, so what I'm going to do, I have to check the fundoscopy. All right. So what I'm going to do, I'll quickly go through the past medical and lifestyle history. Again, I can skip all these things. So do you think it is really important for me to ask, do you smoke, do you drink alcohol, how's your diet, how's your physical activity? No, remove those questions, rule them out. You don't need to waste your time there. All right. So what you're going to do, fundoscopic mannequin is there. So I'll do the inspection. If you have time, you can do inspection. That's fine. And the patient has got blurring of vision. Should I go for visual acuity with the help of Snellen's chart? Of course, you can do. And if you don't have that, you have got your fingers. You can do finger counting as well. And then what you will be doing? You will be doing fundoscopy. Please do not forget to prepare the patient. How are you going to do the preparation of the patient? Again, I'm repeating it. So how are you going to do the preparation of the patient? Very easy. You will simply have to dim the light and eye drops. Fine, eye drops. What you're going to do with the eye drops? And make sure you rule out angle closure glaucoma. And also mention that don't drive, don't sign any legal document, and don't operate on any heavy machinery. Now, what you're going to get in the fundus, that's the thing. So you will be getting papilledema. What you will get, disc margins are obscured and swollen, and retinal vessels show tortuosity. That is what you will see in the papilledema. And it is going to be bilateral. Both the eyes, you will have this papilledema. All right. Patient might have high BMI as well, but not mandatory. All right. Now the management. So what you're going to do, you'll be discussing management. So management would be what? First of all, patient might be in the GP surgery. Patient might be coming to the A&E as well. So if it is GP, what you do, you will be going for immediate referrals as well here, right? So what is going to happen? You have to do the scans only. You have to do the scan only, and most probably it could be SOL. That finding that I've got a headache in the morning and I've got blurring of vision when I'm bending forward, it is a typical sign of intracranial hypertension, and the most common reason for it is space occupying lesion. So what you need to do, you simply have to make sure you do the scan to find it out, and then the treatment is what? You take it out, that's it, you remove it. Yeah. And meanwhile, sometimes you'll see we might be giving diuretics to the patient, we might be giving steroid to the patient. Sometimes we have to put some shunting and all those things as well. But that's going to be too much. First, get a scan done to find out the main cause so that you can treat the patient, manage the patient accordingly. Patient has got headache, give something for headache as well. And tell the patient not to drive as well. Yep. All right. Let's have a look at this scenario as well. You are in GP surgery. A patient has come for diabetic annual review. He was diagnosed with diabetes and was put on insulin. Examination has been done by the nurse. Patient has got loss of fine sensation and pain sensation below the ankle bilaterally. Urine test shows patient has got glucose and protein. The blood pressure of the patient is 130/70. BMI is 30. Talk to the patient, do the diabetic annual review, and discuss the initial management with the patient. Discuss the management with the patient. Okay. So first of all, you need to know what actually we do when the patient is coming for diabetic annual review. So this is your diabetic annual review chart actually. Diabetic annual review chart. So what are the things you do? We do check HbA1c, that's your 3 months blood sugar. We check blood pressure, we check cholesterol, we do kidney function, we check BMI, we check eye examination, we do foot examination, we check injection sites if your patient is on insulin. This is what we do in the diabetic annual review. As simple as that. Okay, so patient has come for diabetic annual review. Yeah. So what you will do here in this scenario. So ask the patient, first of all, elaborate about the diabetes, like you have come for the diabetic annual review, for how long you are diabetic, and if your diabetes is well controlled or not, what are you taking for it? Are you checking it regularly? When was the last time you checked? What was the reading? Whether it was before meal or after meal, right? And then you can ask the patient if patient has got any symptoms of diabetes or not. Then you can ask if the patient has got any complication of the diabetes or not. Symptoms of diabetes: are you going to the loo more often? Are you eating more than usual? Are you drinking more than usual? And then complication: you can have microvascular complication, you can have macrovascular complications as well. Micro is like any eye problem, numbness, tingling in the legs, or you can have macro like chest pain or kidney problems. So that is something that you can ask about, right? So a brief history about the diabetes you can take. So, and in the past medical history, you can also ask if the patient is attending all the annual reviews and patient has attended all the GP reviews about diabetes or not, right? That's something, 2 minutes of history we can take. And obviously now, in the past medical history, you can ask if patient has got any other medical condition. Which medical condition we are looking for? Hypertension. Which medical condition we are looking for? Cholesterol. Which medical condition you're looking for? Kidney problem. Why I'm saying all these things? Because that is what we actually do in diabetic annual review. Okay. Now, after that, any medication you're taking, any allergy, any surgery, any hospitalization, family history, can I skip these questions? Of course, yes. Now you'll be saying, in diabetes, I should ask family history. You can ask. But the thing is, this patient is diabetic, say, for example, for last 5 years. And if he says, yes, my father is diabetic as well for last 20 years, is it helpful? Not really, not really. If you diagnose this patient the first time, it is going to be making more sense asking about family history. But here, if I missed family history about diabetes as well, it's not a big deal. It's absolutely okay. Yeah. Now, when it comes to lifestyle, smoking, diet, physical activity, is it important? It is very, very important here. I know for the last few stations I might have said it's not important at all, but is it important in this? It is very, 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 very important. Don't miss it. So this is how you will be doing your history. Now, in this station, when you entered, what happened is you have got a fundoscopy mannequin again. You have got a fundoscopy mannequin again. So the thing is, in diabetic annual review, what are the things you do? What are the things you do? You check BMI, you check blood pressure as well, you do eye examination, you do foot examination, you check injection sites as well. So if you check the question, you have been given the blood pressure, you have been given the BMI as well, you have been given the findings of foot examination as well. There's a loss of fine sensation and pain sensation below the ankle bilaterally. What is the thing that they have not given to you is the fundoscopy finding, and that's why fundoscopy mannequin is there. And what you will do in this particular station, you will do fundoscopy. So what you can do, you can start with the inspection if you've got time, then you can do visual acuity with the Snellen's chart. And if it is not there, you can go for finger counting as well. And then what you have got, you will go for fundoscopy. That's it. You will go for fundoscopy. Right, that's what you need to do. And don't forget to prepare the patient when you do fundoscopy. What you have to do? You have to dim the light. And what else you have to do? You have to put the eye drops. You have to put the eye drops as well. Yeah. So don't forget to do these things in the exam, right? So when you're putting the eye drops, just don't forget few more points as well, like uh, 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 ruling out acute angle closure glaucoma, and don't operate on any heavy machinery, don't sign any legal documents, all those red flags you can mention, and then you will get this in the fundus. So that's your diabetic retinopathy. So maybe pre-proliferative, yeah. So you will see dots and blots, hemorrhages, right? Cotton wool spots you will see in the picture. So this is what you might see. So verbalize it, that it is what I can see in this, right? And this is your diabetic annual review chart. Now, what is the management? So management is what? Management is doing further investigation. So management would be checking your random blood sugar, doing your HbA1c check, doing your cholesterol level check, doing your kidney function check. From where I got to know this information? Because this is what is there in your diabetic annual review. All right, so that is the main thing. And what else? What else? What else? And then you explain the fundoscopy findings as well, what you have got. Now you can explain it to the patient as well. Then when I examined your eye, what I could find, there are certain changes in the back of your eye. And that is one of the complication of diabetes. See, diabetes can affect your like small vessels, can affect your big vessels as well. When it is affecting your big vessels, it can lead to the problem in your brain, in your heart, in your kidneys. But when it affects the little small vessels, it can affect your vision as well. So that is what has happened in your case, and what we call it as diabetic retinopathy. Right. So the management is what? Obviously, you need to refer this patient to the specialist as well. Tell the patient to have a good control over diabetes as well. And we'll be making the changes in the medication as well and diet control. And specialist will be mentioning about the final treatment plan. Okay, so this is what we have got in diabetes, diabetic retinopathy. Right, so fundoscopies, I've discussed you the 5 scenarios here, if you see. So I've discussed the normal fundus, which was in giant cell arthritis. There could be CRAO as well if the finding is for a few hours. Then I discussed the retinal detachment with you. Then I discussed the ocular toxoplasmosis. Then I discussed the ICH, intraocular hypertension and papilledema. And I discussed the diabetic retinopathy. Patient came for diabetic annual review. Right? And there was another scenario that I discussed where you were supposed to do the peripheral field of vision. So that's your eye examination. All right.